Chairman, and many thanks to Professor Hany and the organizing committee for the kind invitation. I'm afraid this is another one of the catastrophic cases. Okay, so endovascular branch grafts are increasingly used to treat aortic arch pathology. And this is a paper from Dr. Kobel's group who reported their 20 cases of treating arch pathologies. And they concluded that actually this is a procedure with acceptable risks and mortality with low stroke rate as well. For those of us who are not familiar with the device, it essentially comes with inner branches here here, and essentially what I want to draw your attention to are these markers who appear as a long line, and they should always be directed or oriented towards the outer curve of the arch. This is obviously this is a Cook device, and it's a self-oriented device, so meaning that it takes the arch of the aorta spontaneously, which directs the branch towards the aortic branches. I'm grateful to my colleague Zayed who passed on these slides to share with you. Essentially, this is a 76-year-old gentleman who in 2012 presented with a rupture descending thoracic aneurysm for which he had a T-bar. 1 year later, he presented with symptomatic type 1A endoleak and had a proximal extension. 2 years afterwards, he had an open repair for a symptomatic penetrating ulcer of the ascending aorta. Unfortunately, in 2017, he presented with a large type 1A endoleak, as you could see here. And this was the sort of initial drawing of the graft, where essentially will land in the prosthetic graft, and there are the two branches to the, one of them for the brachiocephalic trunk and the other one for the left common carotid artery. Obviously, in preparation, we needed to do a left carotid subclavian bypass, as you could see here. But this was the beginning of the problems in this patient, is that there was a dissection, and you might see it here, just at the level of the distal anastomosis. The patient was symptomatic, so immediately post-operative, he needed to have a stent going through the anastomosis. This is on the day of surgery, and this is the old stent graft, and this is the arch branch device before deployment. And I just want you to notice a few things. So as we said, this is a self-orientated device, so it's taking the arch of the aorta. But I just want you to see that actually the long markers here are not pointing towards the arch branches, they are all pointing towards the inner curve. We had a discussion of the company represented at the time, and they were quite confident that this, as soon as the stent comes out, it will self-orient itself. Well, we listened to them, but actually you see after the deployment, the branches are completely in the wrong direction. So effectively what we've done now is we covered the origin of the brachiocephalic trunk, the left common carotid artery, and the branches are directed towards the inner branch, which is going nowhere. And this was the feeling in theater at the time. What to do, and obviously we need to do something, and whatever we do, it won't be an easy option. So we elected to try to proceed to recanalize it, and I just want you to imagine how difficult it was to get the access from the brachiocephalic trunk with the catheter in front of the device, try to cannulate the inner and the lower surface of the stent graft. Luckily, after multiple attempts, we were successful to do that, but because obviously of the mal-deployment of the stent, it was very compressed, and when we put the brachiocephalic branch, it was very compressed. We had to use a high-pressure balloon to open it and reline it. Then we come to the left carotid branch, and because of the tortuosity and the carotid subclavian bypass, it was very difficult to cannulate the branch, and even after successfully cannulating the torch after multiple attempts, it was very difficult to track the sheath into the branch to get a stable position. But again, after multiple attempts and a bit of time, we were successful in stenting the left carotid branch, but this was not the only thing. We had to use lots of balloons and lots of stents to reline it to counteract the effect of the compression because of the mal-deployment. Luckily, after around 6 and a bit hours, this was the final picture, and you can see the stent is here, and the brachiocephalic branch is coming above, in front, and inferior to the stent graft, and you can see the left carotid branch is coming again, taking the same route. And you can see here lots and lots of lining stents to try to keep the stents open. Obviously, it was a left brachial artery cut down repair at the end. The patient post-operatively, unfortunately, developed expressive dysphasia. However, this improved within 2 weeks without any intervention. Had multiple CT scans. We usually scan them every year, but because of this challenging case, we went for 6 months. And this is the initial CT scan. I just want you to imagine the stents actually arising from the undersurface of the stent graft and taking a very tortuous course in front of it. However, having said that, the target vessels look well perfused. And this is just slices to show you this is where the stent is starting in the undersurface, then in front and above the stent graft. Probably this is more easy to appreciate on the reconstructed images where you can see the stent arising from the undersurface, then going in front and then into the branches. Few learning points. I mean, we were lucky to get away with it, but the first thing to understand is that having a T-bar inside the aortic arch probably have an impact of the dynamic of the thoracic aorta, which might affect how the stents will behave in a second stage. The self-orientation, it's a good idea, but should not be taken for granted, and we have always to trust the markers and make sure that they are in the right place. Always we need to have a plan B, C, and D, and these type of operations are very complex with very high stakes. If things go wrong, the patients can really get harmed. So we have to have access to all the facilities that we can use to bail ourselves out. Thank you for your attention.
Thank you. Very interesting.